welcome to the Dive into Health MD podcast.
I'm Divya, an emergency physician.
And I'm Akshita, a radiologist.
We're here to talk about medicine and whatever else we're curious about. As a disclaimer, we do our best to stay up to date, but science moves fast, and so we always leave room to evolve our thinking.
All right, let's dive in.
All right, so for the first episode, we wanted to meet the hosts and introduce each other. So, Divya, you are up first. What's the 30-second version of who you are and what you do?
I am an ER doc, primarily. I have a fellowship in administration, so I do a lot of hospital stuff that nobody wants to do, basically. And I'm also board certified in lifestyle medicine, which is maybe the opposite of emergency medicine in a lot of ways, but it focuses on how to use your lifestyle to be healthy.
Awesome. When did you first think, yeah, I'm doing medicine? And why?
I don't know if you know this, but I'm brown. No, I'm kidding. So of course I am brown, and of course my parents are very happy that I'm a doctor, but I'm from New Jersey. And in New Jersey, there's this weird thing where they were really, really desperate for EMTs at one point. And so you can be an EMT at 15 and a half, I think is the cutoff. And for some reason, me and my friends in high school were like, yeah, we want to be EMTs. We think that's cool. And honestly, the rest is history from there. So I became an EMT, then I became a type of paramedic called EMT critical care, which is like a step down from paramedic. And then I went to med school, and then I specialized in emergency medicine, and here I am.
Nice. And why emergency medicine? Did you consider anything else?
I did. I think this is maybe a stereotype of emergency medicine, though, that we're those kids in med school that were happy in every rotation and could have easily done any rotation. And when we were on that rotation, we're like, yeah, I'm definitely doing this. And then when you sit down and look at your scope of everything you've done in med school, you're like, wait, what field covers everything? And that's emergency. And that's kind of how I ended up. Plus, I guess I should have seen it written in the stars, given I started off my career as an EMT.
Yeah. I feel like you were talking about cardiology for a while, too.
Yeah, exactly. I went all over the place. I applied to internal medicine, actually. I don't know if you remember that. And then I really liked peds. I really liked OB. I considered psych for a hot second. I even considered surgery for a second. Like, I did everything. Oh, anesthesia. Anesthesia was my other real intense one that I was like, oh, I might gonna be an anesthesiologist.
What do people get most wrong about your job?
That it's the pit. Have you seen the show?
No, I
it's
like
a show that
clear of medical shows. I saw Grey's Anatomy for a little bit, a couple of seasons, and then that is literally the only one. And I was like, I get enough of this medicine crap in my life. Like, I have no interest in adding this to my TV regimen.
Well, The Pit, it came out kind of recently, and it's actually really good. It's really accurate. The main two things that I couldn't even fully watch the show because the entire time I was watching it, I would be sitting there like trying to memorize everything that the patient said and all of the things that they did and ordered, because in my brain I needed to go back and write notes, which they never show in the show.
They never show the doctor
really annoying. Yeah, no, there's no one writes a singular note in that entire show. And the other thing is, like, each episode is an hour in the emergency room. And so, like, there's crazy stuff happening back to back to back to back to back. So now people have been coming up to me and being like, is your job that crazy? And I'm like, yes, actually, it is all accurate, but I don't get all of that in one shift. Like, maybe that 1 hour is my entire shift. One crazy thing happens.
Not back to back. But yeah, writing notes is a pretty integral part of the day. So very convenient that they left that out. But man, there was so much that was inaccurate about Grey's Anatomy. Those residents were like the ER docs plus the surgeons plus every other subspecialty made absolutely no sense. So,
but that's why The Pit is so good. It's like actually accurate, and it shows actual like hospital dynamics and like our code words and stuff.
Nice. Okay.
They're giving up.
I don't know the answer to this one, but I'm going to see if you say what I think you're going to say. What is your actual superpower at work? What are you unusually good at?
Probably efficiency.
Okay, that's not what I thought you were going to say, but...
What were you going to say?
Finding the appendix.
For context, Akshita has been my CT scan reader mentor, and she's spent an enormous amount of hours trying to teach me how to find that appendix, and I still can't find that appendix.
Dude,
Still can't find it.
everyone could read their own scans.
I do. Actually, did I tell you this? I have a reputation now as the person that reads their own scans. And like people will come up to me and ask me for advice on how to read the scan, and I'm like, what? And then I'm like, oh wait, yeah, I just kind of sometimes do know what I'm talking about.
Yeah, you told me that. That's why I thought that was going to be your superpower, that you were like the ED radiologist.
The ED
But man,
radiologist.
like, you guys see the patients. Yeah. Yeah. So cool. So cool. I'm glad that I could influence that on you. Also, Neil, our friend, I got him to actually put indications when he orders radiology scans.
Yeah.
And I would like to say that's a superpower. But what is the hardest part of your job that outsiders don't see?
It's a hard question to answer because I would say the emotional weight of everything that you're trying to see and handle, but it's not in the moment. Like you'll see a really tough case that's really sad, some, horrible trauma or some horrible diagnosis of cancer, but then in the next second, you have to walk into a totally different patient with a totally different complaint and then have forgotten in a sense that what you just experienced. And I think that rapid switching is really hard. Though I don't know, I think that maybe most people know that about the ER, maybe? I don't know.
I bet a lot of people don't think about it. So that's probably helpful. Do you debrief at all? Or do you get any of that?
Yes and no. I mean, we do try to take for example, if someone dies, we all do pause and do like a moment of silence. Or if we have a really tough medically complex case, I'll try to debrief it in that we'll talk about really quickly what went wrong, what happened. I do think as a resident or a med student, you have more time like that. As an attending, you don't have a choice. You have to see the next patient.
You just go.
You have to, yeah. You don't really have a choice in the matter anymore. And to be honest, the hospital system probably doesn't care about you that much anymore. So like they don't give you the time anymore to debrief and take psychological breaks.
What do you wish every patient knew before coming in?
I think people don't understand what an emergency room is. Unfortunately, most people come in hoping for an answer. And I will say the vast, vast majority of the time, I cannot give you an answer. Most people are looking in, they're coming in with, say, chest pain, something simple. Well, I can't say chest pain is simple, but something straightforward. And they're like, what is causing my chest pain? And fix it. And neither of those things am I often actually doing. Usually I'm giving maybe a pain medication to band-aid over the pain for a little bit, and I'm ruling out emergency things. And then the rest is up for your primary doctor typically, or specialist or outpatient team to figure out. And I don't think people understand that. And so they often leave feeling really unhappy with their ER visit, not understanding that this is like fundamentally the role of the ER. And I also hear this thing that patients will say is like, they did nothing for me. What they're not understanding is on the back end, we've ordered a ton of studies. We've ordered a ton of imaging. We've reviewed your chart. We've actually done a ton of stuff. But to them, it feels like we did nothing because we are not able to tell them what it is and fix it.
Yeah, but you're making sure that the emergent critical things are not going
Exactly.
on. And then if they're going home, they're going home at least stable.
Yeah.
Which is huge.
Yeah.
And not always straightforward. And not always easy to do. Depending on the person. So yeah, that's cool. What do you wish every doctor knew about your specialty?
The same thing. I cannot tell you how often outside care people, sniffs, even actual other ERs will send people to the ER being like, do something. And we're like, what do you mean? So yeah, really the same thing, that the ER's role is purely to rule out emergencies. Sometimes we get lucky and we can make a diagnosis. So that's the rare case, not the rule.
What do you want this podcast to be? And what do you want it not to be?
For me, I miss what we had in med school, which was a forced way of formalizing talking and while learning simultaneously. Friendships are interesting, especially as you get older, in that it's hard to keep in touch with people, even the people that are your best friends, because you'll call them up and you'll be like, what's new with you? And you'll chit-chat a little bit about stuff, and then you'll kind of fall out of touch and you'll get, call each other again a month later. And I think the one nice thing about training and being in school is that you are forced to be with each other because you're studying together or you're, trying to figure something out and teaching each other. And I really want this to be more of a between us way to keep that kind of spirit alive.
How much time do you think we spent together in med school?
How much time did we not spend together?
Okay, that's fair. What topics are you excited to argue about?
Oh, argue about whole body MRIs.
Yes. I am here to argue with you about that. What's your we're not giving advice line for listeners in your own words?
It is actually an art, not a science. And so
it is a
practice. Honestly, you cannot give advice without knowing the background of that specific case.
Yeah. I mean, it is helpful to provide education and to talk about how the body works and physiology, common disease processes, but to take any kind of direct guidance or, advice is not possible unless you have a specific relationship.
Yeah, and arguably dangerous.
What's one non-medical thing that makes you interesting? Can I answer this for you?
Yeah.
This has to be a part of the video component, though. You have a wine book that I think makes you incredibly interesting.
Are you outing me?
I am. Yes, absolutely. This is this book that you have written. So I'm assuming this was like an empty journal, or I'm sure it was, right? And as we have been learning about wine, and then you have gone way above and beyond and studied way more than I have, but you have filled out an entire journal, handwritten with an index about everything related to wine.
But you said like it's unique to wine. I just like writing things. And maybe that's what's unique about me. I really like stationery.
Stationery? I think you like learning.
Oh, I also really like learning.
Okay. Well, that is all of my questions for you.
Okay, so let's start with, what is your 30-second version of who you are and what you do?
Okay, so I am also a doctor. We met in med school. I went into radiology and then further subspecialized in neuroradiology. So professionally, that is what I do. I am also married and have 2 kids. And then starting this company, Dive into Health, and really kind of stemming from just seeing a ton of chronic disease. And in med school, that was obviously in the hospital and in clinics and dealing with patients who were varying levels of sick. But then as a radiologist, seeing it day in and day out constantly. So when you're practicing medicine clinically and you're in front of patients, there's only so many patients that you can see in a day. Depending on what you're doing, that might be like 15 in clinic or 20 in clinic or 30 or something like that. When you practice radiology, that number multiplies. And I can see hundreds of scans potentially in a day. So the amount of disease that I was seeing going from clinical medicine to radiology training was so much more. And so I think just being inundated, and I mean, almost like what you were saying in emergency, it's almost like it's like playing roulette every time you open a case. If I close a case, another one just kind of pops open and you have no idea what it's going to be. It could be a totally normal case. It could be a massive brain tumor or pancreatic cancer or something absolutely terrible. And you never really know what you're in for. And it can sometimes be a little bit of a surprise and kind of heartbreaking. And then very similarly, you close a case and you report it. And oftentimes, if it's bad, you'll call the doctor and tell them what's going on. And then you just open the next one and you keep going and you keep going and you just do this day in and day out. And so there was just this, kind of string of lots of chronic disease day in and day out. And so we've been, for our own health, learning things that we can do to try and stay healthy. But then maybe one day being able to teach this to other people.
And maybe you kind of covered this with that answer, but one question that we often got when we were at the lifestyle medicine conference was, you're a radiologist. You don't see patients. Why the heck are you getting a board certification in lifestyle medicine?
Yeah. So there was definitely this point where I was like, man, early career, am I really just going to talk about the same disease processes over and over again for the next 40 years? Is there anything that we can do to try and prevent some of this or just play a different role in medicine? And so you and I did a board certification in lifestyle medicine, and we went to the conference, which is part of getting that certification. And I am sure I was the only radiologist there and got this question all the time. What are you doing here? Are you going to take this back to your patients? This makes no sense. And at the time, I had no idea, but I ended up getting really interested in food and learning a lot about food and food quality and how to find quality food products and how vastly different food products on the shelves are in grocery stores. And so that's kind of where it started, and then started building a docuseries, and then, but also was still very interested in all other aspects of health, like sleep, which I've had issues with, and movement and exercise and a whole bunch of factors. And then so that's where Dive into Health came from.
What is something that you're still bad at?
A lot of things. I think that's the beauty. There's always room to go up with everything. I mean, medicine is endless. I think one of the coolest and most humbling parts about being a doctor is experience is definitely, I think, the one thing that you can't trump. I mean, you can read every book under the sun, but the experience is really, I think, what makes you a good doctor. But even doctors who have been practicing for decades often see something new, see something that they don't know. And when I was choosing radiology, someone mentioned this to me, and they were like, if you're going to go into this field, be prepared to be humbled. You will never know what is on the next scan every single time. Every single day that he practices, he still says that he finds something new, and he was like in his 50s. And that's entirely true. I saw something this morning already that I had just never seen before, and it's a weird orbital mass. It looked very strange on MR compared to CT, and it's really humbling. You can try really hard, but there's endless.
I mean, and in that line, is there a particular miss or a particular like common thing that you're the most worried about missing?
Most worried about missing? I mean, I think it's the thing that you don't know. I think that's the challenge. And I think that's something that we learn through training, which I feel like is almost one of the most beneficial things. I think you get to this point in medical training where you're getting in a little bit of confidence and you're like, oh, I know things. I can take care of patients. I can treat pneumonia and heart failure. And then you keep going and you're like, I know nothing. Because the thing that's scariest and the thing that I'm going to miss is the thing that I don't know.
Yeah, so true. I feel this every day in the ER, constantly.
And that's the challenge of the ego when you see someone who is so confident about something or so confident that they're not going to miss something. I think that's honestly like the person that's scariest. Because you're not.
Yeah, when I think back to my like most impressive attendings when I was training, it's the people that were like looking up stuff on Google or looking up stuff on UpToDate or whatever. Those were the people that I thought were the most impressive, not the ones that were running around just being like, I know the answer to this.
Yeah, because you have to stay open-minded and you have to always think about, well, what else? Because if you see a mass in the parotid gland and it looks the same as another mass that you've seen, then you're just going to call it that thing. But if you're not open to it being something else, you're never going to realize that it actually was something else. And we learn rules, like brain tumors sometimes are hard to see on non-con head CTs, which are ordered very frequently, but that's not a rule. You can find them if you look for them. And they're hard and they're subtle sometimes, but if you know what to look for, if you have the experience, they're there. So always being open-minded and always realizing that there's more to learn and there's just stuff that you haven't seen before.
Speaking of masses, what's your take on incidentalomas?
I don't know if this is controversial. I mean, I think they're challenging to deal with. Okay, so an incidentaloma, what is that? That's when someone orders a scan and we find something that we weren't expecting. So someone orders a CAT scan of the abdomen because they're suspicious for appendicitis. Maybe someone comes into the ER and their abdomen's really hurting and the ER doctor thinks that they might have appendicitis. Reasonable to order a CAT scan of the abdomen to look. And then I, as a radiologist, would read that scan. But what if I see a lesion in the kidney, right? What if I see a lesion in the pancreas? That's what's called an incidentaloma. Or oftentimes when we get a CAT scan of the abdomen or pelvis, we get a little bit of the lung bases. What if I see a nodule in the lung, right? What do you do with that? And the challenge in medicine is, well, what do you do with that? And ethically, once you see something, you kind of follow it until you figure it out, right? You can't leave a potential lesion in someone that could theoretically turn into a tumor if we don't know exactly what it is and not do anything about it. So what happens is we end up following these things. And there's a lot of downsides to that. The downsides are, one, you're more often than not asking for more radiation down the line, right? And then the two is you're giving someone a ton of anxiety, right? It's never fun to say, hey, you've got this little thing in your pancreas. I don't know what it is. In 6 months, let's get another scan and see if it changes. That's incredibly anxiety provoking for someone, which is tough to do, but you're not going to not do it, right? You kind of end up having to follow these things until you get an answer. And sometimes the best thing to do is follow it for 5 or 10 years. Sometimes there are some really slow growing tumors where you almost need like 5 or 10 years to decide, hey, I think this is benign, has not changed. Now we can let go. That's terrible to do to a patient. But if it's something also like a pancreatic lesion, you're not going to biopsy that thing, right? It's not a safe place in most instances to biopsy. Now, there are some lesions in a very specific part of the pancreas, like the pancreatic head, where you can do like a transdural biopsy, and it's maybe not that risky. But for a lot of things, it's not worth it to biopsy it. So then you literally just scan it. So, I mean, I don't think that there's a better answer. I think a lot of times the best answer is don't intervene, right? Don't do an invasive procedure because there's risks of that. But the downside is a lot of anxiety, time, and money, and potentially radiation. So that's not like good either. But this is also why you don't want to over image.
Yeah.
Because people want scans of their body, right? It's almost like a reassuring thing. And then there is something called like a therapeutic scan. It's like something that we talk about where, especially in residency, we would call a clinician and say, hey, like, I don't think this scan's indicated, based on your note or based on what you're saying. I don't think this person really needs it, or I'm not going to be able to give you the answer based off of this. And a lot of times it wasn't an emergency medicine physician of like, look, this patient really wants a head CT. They don't want to leave until they get it just to make sure. And I don't know, like sometimes it happens where we just scan them even when it's not indicated. And I would just say the most that we could minimize that and scan when medically indicated, we're going to reduce the amount of insulinolomas that we find, because the vast majority of those incidental things end up being nothing.
Well, this transitions us nicely into my next question, which is how do you feel about whole body MRI?
Oh, okay. All right. So my take on whole body. So this may change over time, but today, originally I was way more against it because I've never read these. So I'll say that disclaimer, but originally what I had heard when they first came out is that these were essentially not diagnostic. At least a lot of them were. If you think about an MRI, the way that it happens in a medical setting, so we image a very specific part of the body, depending on what you're looking at. It could be the knee if you're looking for a meniscal tear, an ACL tear. It could be the head if you're looking for a stroke or something. And the reason that we do a very specific body part is because there are these things called coils, which we need to put in close proximity to the body part that you image in order to get enough resolution to make a diagnosis. So if someone wants a MRI of the entire spine, that is a massive area to cover, it's 3 separate MRIs. We order MRI of the cervical spine first, and then we do the thoracic spine, which is the middle spine, and then the lumbar spine, which is the lower spine. We don't have an MRI of the whole spine. It's too large and the resolution wouldn't be great. And so when whole body MRIs came out, at least from what I've heard, initially, if you're imaging the entire body, the resolution wasn't diagnostic enough, and it kind of sounded like a scam. Now, obviously, they've been out for quite a while. Technology changes really rapidly. And from what I've heard, the resolution is actually decent, and you can find things. But I think this ties into the incidentalloma thing. Right now, there's no guidelines for everyone to get these done because I think, at least in many cases, we are doing more harm than good. And almost bi-directionally, someone may get false reassurance thinking that they got a body MRI, it was negative, and then there's nothing going on with them, which you can't find everything on imaging. And then the other way around, we might find like an incidentalloma, and now a person's panicked, and it ends up being like a benign lesion that would have never turned into anything, and you could have like died never knowing that you had this thing and would have never caused you worry and would have never impacted you from a health perspective. And there are unfortunately a lot of things, maybe not a lot, but there are several things in the body that are like that do not harm you, do not kill you. They just happen to be there in some people. And so that is my main argument against the whole body MRI, because I think a lot of people that also are inclined to get these may be a little bit more anxiety prone or worried, and that's why they're willing to spend so much money. And so then if it comes back saying, hey, there's this thing in your pancreas, you don't know what it is, like, that's horrifying. Could be to some people. And I think in some instances, it's probably doing more harm than good. Now, of course, there's always the argument out there, someone had one and they found an actual kidney cancer. And I think that's like the most common, example I've seen, and get a renal ultrasound. I don't know. Of course, if you image everybody, you're going to find things. But I think it's also feels like not the right answer to say that every single person should be getting these.
Pivoting a little bit, if you weren't going to be a doctor, what would you be?
I have no idea. I don't know. I think if I wasn't going to be a doctor, I think teaching. I like teaching. I also really like learning, and I like teaching. I like synthesizing information and finding a way to make other people understand it. And so I have 2 kids now. My oldest is 4, so I have little kids, and it has been really fun finding ways to teach through play. And so I don't know, maybe like an elementary school teacher or something would be fun. Being with kids all day is like so cool. I think, and maybe it's like such a dichotomy from being in the hospital, right? Like they're so excited about everything. Like a leaf could fly by and they're like ecstatic. And everything is so happy and like sparkles and rainbows, as opposed to the feeling sometimes of, you know, being in a hospital for a long time, that maybe that's it. But the energy of little kids is like kind of magical. So maybe that.
And finally, what do you want this podcast to be?
Want it to be, I want it to be fun. And I want it to be a space where we can learn and where we can learn together and hopefully have some really cool conversations with people from different walks of life doing really cool things. Basically, like almost like a compilation of just people trying to make the world a better place. So like including doctors, but then a whole bunch of other people. So I think what's interesting about medical school is you get exposure to so many different types of doctors and so many different specialties. And once you become an attending, it can be a little bit more isolating. I mean, I do talk to emergency medicine doctors probably the most, and I do occasionally talk to primary care doctors, but these are not like extended conversations. At least for me, it's like, hey, your person has a stroke, or they don't have a stroke, or hey, you're, you know, like primary care, this person, incidentally, I found this mess that we need to follow. But I don't get a lot of in-depth conversations about what their practice is like and the types of things that they're seeing and the problems that they're running into. So I think this would be a cool avenue for that. But I think also even getting away from medicine, because also learning like there are so many other things that are impacted that impact our health. And so talking to farmers has been fascinating. Talking to people in the food production industry has been fascinating. I also want to talk to people in the finance world. And that's another huge part of the Dive in Health series, tying finance into health, because a lot of people make food and stressful and health decisions based off of financial reasons. So yeah, I think in general, just a space for us to learn, to talk to a lot of really cool people and grow ourselves.
That's our show for today. Thanks for hanging out with us.
Reminder, this podcast is for entertainment and general education, not medical advice. If you've got a health issue, talk to your own clinician.
If you like this episode, subscribe, rate, and share it with a friend who enjoys medically adjacent chaos.
Until then, be well, be safe, and don't take life or us too seriously.